Hi everybody, welcome to our fourth webinar. So tonight we have Dr. Dom Ronan. He is currently at work, so very kind upper GI, where he helped to teach lots of the FI1s during his time there. So you've got a great understanding about the expectations and the roles of F1s. He's always really keen to teach and offer advice. So tonight, before I hand over to Dom, there'll be an opportunity to ask questions. We'll answer these as we go along best we can, and then Dom can also answer some of these questions towards the end. Without further ado, over to you, Dom. Thanks very much.
Hi, everyone. I'm Dom, one of the CT2s working in Sheffield at the moment. So I'm going to share my screen with you to show the presentation. Unfortunately, you won't be able to see me in my post-shift state, which is probably for the best for everyone. But what we'll try and do is have a bit of a brush through upper GI complaints from a general surgical point of view. So without further ado, I hope everyone can see that. And I think firing questions throughout, we'll try and get to some of them throughout the presentation, and we will answer some of them at the end as well. So a quick, brief overview about what the sort of plan is. We're going to go through kind of three main areas of upper GI surgery. The first being kind of haematemesis, what can cause it, investigating management, different aspects of haematemesis, what to do in kind of a massive scary upper GI bleed. Move on to a bit of swallowing problems and kind of acid reflux problems, dyspepsia. Again, causes presentation management, a little bit about the background, and a little bit about kind of surgical problems and how we can stop them with surgery. Moving then on to a bit about jaundice and what we can do surgically to try and help things there. I'm going to add on a little bit about pancreatitis just because I think it's quite important at the end, especially for you guys when you're starting, if you're faced with a couple of these very unwell patients. And then I've got a bit of a slide at the end for general advice of starting as an F1, which hopefully should be fairly useful, because it's not that far away now for you guys. So initially we'll start with kind of a little case of a fellow, 57-year-old, lives alone, he's furloughed at the moment, drinks loads. For any of you that are struggling to put kind of drinks into units, if a patient says, oh, I drink 7 cans of alcohol, basically just take the volume in litres. So if you think a 500 ml can of beer, of 5% beer, and just times it by the percent of ABV, and it'll work for everything. So regardless of what it is. So for example, 700 ml bottle of 40% spirit, 0.7 times the 40% should give you 28 units, which is how many is in a bottle. So it's just to make sure you know a quick way of working out the units that are clinically relevant from the patient who doesn't know what a unit is. He also had a little bit of excess last night. It was his birthday. He suffers from heartburn, he's overweight, he smokes, he's previously had some surgical management for some acid reflux. So, I mean, he's not a great specimen. Risks and history are things that you need to elicit from the history when you're having a chat with these patients. See what medications they're on that can cause problems in the tummy. So antiplatelets, anticoagulants, of course, they're going to increase your risk of bleeding. Non-steroidals and steroids, unfortunately, also increase the acidity of the stomach. Looking back into the history, a previous GI bleed increases risk of a further GI bleed. Unfortunately, hematochezia, passing blood, fresh blood PR as well. Unfortunately, in massive upper GI bleeds, you can get fresh blood coming from the rectum. So just be wary of that if you kind of keep your differential broad. Chronic alcohol use is also a big issue for things to get back in the history. And then indirect symptoms that might not come out initially, but if you pull them out from the history, syncope, dizziness, that sort of things suggestive of anemia can also suggest a bit of bleeding. Weight loss and jaundice go hand in hand with poor liver function as well. So going back to our patient, he woke up this morning and started vomiting profusely. Just stomach contents initially, but unfortunately suddenly turned to blood. at which point he attended A&E, and you are now seeing him. So in terms of a differential diagnosis here, this guy could have any of them. I think if we go back to our very good-looking 57-year-old, he's overweight, he smokes, he's got previous gastric problems. So kind of the differential is pretty broad at this point. The one that you would worry about in a drinker with sudden frank vomiting of blood is esophageal varices, a variceal bleed. This is probably one of the kind of most impressive, one of the scariest kind of presentations that you'll see. It's kind of high velocity, hit the wall kind of fresh blood from the mouth. Kind of you'll know it when you see it. And it's very important to examine these guys fully. I mean, yeah, he's got loads of blood coming from the mouth, but you need to make sure you're not missing anything else. So full exam without compromising the patient. I mean, in this history, whether or not he keeps birds or parrots and might have interstitial pneumonitis is probably unlikely to be useful, but kind of make sure that you dot all the I's and cross all the T's, but quickly. But if in this guy who's bleeding a lot, it's important to resuscitate him early. For those of you that aren't familiar with kind of varices and variceal bleeds as part of liver impairment, basically the cirrhosis and the fibrosis scarring of the liver causes kind of, through various form of steps, increased portal pressure. And once that portal pressure gets up to about 10 millimeters of mercury, you end up developing collateral blood vessels and bulging of the blood vessels in and around areas where kind of anatomically they're anastomosed, most commonly in and around the bottom of the esophagus, the rectum, and kind of less commonly in and around the umbilical vessels. So it's important to check these areas as well, just in case you start plumbing the top side and end up bleeding out from the back side. So make sure that you have looked at everything. This next slide, I do apologise, it is a bit busy, but this is probably one of the most important slides in the presentation in generally resuscitating a patient. So when you first start your jobs, the first unwell patient you come to, you know, all of these steps are probably something that you need to do. And if you go through your A to E, absolutely, but taking most notice of a couple of these points. High flow oxygen, just bang a mask on them. Make sure they're not aspirating or being sick into the mask, so it takes, you know, you need a watchful eye. 2 big cannula, 1 on each side. When you've got the cannulas going in, take your blood off. Make sure you don't forget any of these. And get into the habit, kind of when you're starting and presenting your patients, to justify each test that you do. For blood count, we need to know what his HB is. U&E, we need to see if it's a big upper GI bleed. Your urea can go up as your body digests some of the blood. So have a look for the urea versus the creatinine ratio on your U&Es. LFTs, of course, we need to know how much of to what extent his liver's been affected by drinking. Similarly, your clotting can be prolonged in liver disease, so it's worth noticing how much you're going to need to correct his clotting abnormalities if he needs to go for surgery. Similarly, you need to give him blood back, so cross-match him. You'll see just below, I've got a VBG there and an ABG. I think if you're worried about his oxygenation, then sure, take an ABG. But in this sort of situation, rather than spending more time getting another test from an arterial sample, your VBG will give you enough to go off to start with. It'll give you a lactate, it'll give you an acid-base balance with a similar degree of accuracy of the ABG. So give him some fluids and keep his blood pressure up. Catheter to monitor what's coming out. If you're putting it in all unwell patients, a catheter is going to be pretty helpful. Transfuse him as soon as that blood becomes available. If he's unstable, despite the fluid resus, then just give him O-neg, because you'll be able to see how much blood he's losing. Similarly, once you try to get him a bit more stable, try and focus on the causes. An IV proton pump inhibitor, pantoprazole, omeprazole. In the first instance, don't give him anything to eat, because he's probably going to have to go to theatre if they're unable to stop it with an endoscope, and we'll talk about that a bit later. But let endoscopy know as soon as you think that he's got an upper GI bleed. Similarly, let the surgeon know, because they don't want a surprise in the middle of the night to say that the endoscopist can't stop the bleeding, can you come and open? And as we mentioned, make sure that he's got plenty of clotting factors on board, because that's one thing that's really going to save his life. If you give him too many red blood cells, you're going to derange his clotting even further. So make sure that kind of at least you consider that sort of thing. Worth mentioning, kind of these guys will probably have a lot of pain and a temperature just because of the inflammatory response. Paracetamol in people with liver failure can often accumulate rapidly, especially if you're giving it IV. So just kind of beware, maybe giving a reduced dose of paracetamol, still have a similar effect, but less dangerous to the liver. So once we've kind of ruled out, actually it turns out it's not so torrential of a bleed. It might well be something called peptic ulcer disease. So erosion of parts of the GI, very similar to kind of a mouth ulcer. Again, precipitated by alcohol, smoking, NSAID use, same as the above. Also a very strong association with a little bug called H. pylori. I'm sure you're familiar, but we'll also have a look at that in a bit more detail later on. Two kind of major types of ulcers that you'll come across, commonly kind of gastric and duodenal. Now, they present very similarly, but there are a few things you can tease out in the history that can try and differentiate between the two of them. Most significantly, the gastric ulcers tend to cause pain or indigestion shortly after eating, whereas a duodenal ulcer, as you might expect, the pain comes a little bit further along. Similarly, you tend not to get the retrosternal kind of heartburn typical with a duodenal ulcer, which might help with differentiating. And the important reason for differentiating between them, especially if you're seeing them in primary care perspective, kind of if you're on your GP placement, is that gastric ulcers can be associated with a malignancy. So it's worth kind of looking at a few of the other red flags, which we'll go through. This little slide, it's not very clear, don't worry too much about all the various parts, but just a little bit of knowledge of anatomy with gastric ulceration. If the history sounds a lot like a gastric ulcer, but they've got a massive torrential upper GI bleed, it's worth considering whether they've eroded posteriorly into a couple of these big vessels that you see. I mean, it doesn't get much bigger than your abdominal aorta. And then probably the next one along is right there, the one that's detailed. See if I can make it work. Just around here, which is your splenic artery. Going into that is going to cause a massive bleed, very similar to as if it were a variceal bleed. That sort of thing may well need surgical intervention. So with your patient on the ward who you're suspecting of a GI bleed, kind of, if it's not a torrential bleed and you've got a bit more time, start with the simple investigations first. Blood tests, bedside tests, imaging, and then any special tests. So suspicion initially, get your FBC, urine, and your clotting on the ward. If you're suspecting that this is an upper GI bleed, get an inpatient endoscopy kind of at an early stage and discuss it, so they're at least aware of him. If anything were to happen, they've got him on their radar. Similarly, monitor their bowels, look for any signs of melena. You're probably going to get that's probably going to be the presenting symptom, is a nurse coming up to you with a bowl full of feces saying, I think it's melena, do you mind having a look? Which unfortunately is job as an F1, you probably get fairly commonly on a general surgical ward. So that sort of thing, just start from the bottom up, as it were. Do the simple tests, see if you can get an endoscopy and we can have a look. It's much better doing the test rather than waiting for anything else to happen. Similarly, try and remove any of the causative factors, hold their NSAIDs, start them on a PPI. And also significantly, make sure that if the patient is anticoagulated, then you get advice from haematology, especially with some kind of the antiplatelets, clopidogrel, Pixban, anything without a reversal agent. It might well take a few days before anyone will agree to scope this patient. So that's something that's worth taking a note of. Just kind of as a side note there, most consultants will expect, even if you don't think it's that necessary, a discussion with other specialties as a matter of routine. So if there is a patient on anticoagulation who we think has a GI bleed, it's worth discussing with haematology straight away. Haematology might say there's nothing to do, but at least you've asked the question. Speaking of kind of referring patients and kind of things that examiners particularly and consultants love are scoring systems. So kind of there's two involved in upper GI bleeds, which are worth taking note of, even if it's just remembering the name, because then you can look them up on WebMD or whatever it is. The Rockall score. This particular score takes into account kind of how unwell the patient is, and there's two aspects to it. There's a pre-endoscopy score and a post-endoscopy score. The pre-endoscopy score out of 7, and post-endoscopy score out of 11. Basically, this just has a look at the risk following a GI bleed to the patient. That's contrasted with the Glasgow Blatchford score, which helps identify which patients with an upper GI bleed may be discharged from A&E, or how unwell they potentially can be. So a high Glasgow Blatchford score gives you a high suggestion of admitting the patient and investigating. Whereas similarly, a very low Glasgow Blatchford score, you might see this patient as an outpatient rather than as an inpatient. So when we talk about endoscopy, often you'll hear it referred to as an OGD, esophagogastroduodenoscopy, wonderfully demonstrated by the chaps at North Tyneside. This way you can intervene via the endoscope as well as having a look. These patients will probably need sedation, and so it's worth kind of assessing your patient so you can refer them properly, knowing whether they can lie on their side, shown whether they can take sedation, whether they tolerate it, if they've got an unsafe swallow, are they at risk of aspiration. These things are kind of worth just kind of thinking about from a practical point of view. And if you've got a massive bleed, it needs to be kind of within 4 hours to try and help stop it. Ideally, the sooner the better, because then it gets a better idea about whether there's anything still bleeding there. You can also, at this point, take a little biopsy for a CLO test or a rapid urease test. This is the one that looks for H. pylori there and then. So basically, the H. pylori produces urease, which converts urea to ammonia. So they take a little biopsy, drop some urea on it, and sees if it produces ammonia. And it is also the reason why it's very difficult to do if you've put them on PPI, because urea will turn to ammonia in an alkaline environment anyway. So if you've got them on antacids or PPI, you're not going to be able to get a particularly good result from this CLO test. So that's also worth noting in any kind of referral. That they'd have to, if in an outpatient setting, they'd have to be 2 weeks free of any PPI before you got started with an endoscopy for a CLO test. Other causes, moving on a little bit, Mallory-Weiss and Boerhaave syndrome. You might have heard of one or both of these, and they're basically two elements on the same spectrum. So Mallory-Weiss, often come across as a Mallory-Weiss tear, often brought on by vomiting, particularly after a heavy night, coughing, sometimes more in the elderly, kind of food trauma or any sort of kind of swallowed foreign object. Essentially a partial thickness mucosal tear of the esophagus, cuts into kind of the small blood vessels and arteries within the esophagus itself. Very painful to swallow, but not full thickness. And commonly this all is managed medically or conservatively, NG tube, as long as it's safe. Endoscopy potentially to have a look at the extent of the damage, but a lot of the time this will just be managed with a bit of rest from food. Boerhaave's, however, on the other side is something a bit more significant, often associated with cancers of the esophagus or major trauma. There was one that I saw fairly early on where Peripheral Hospital had managed to insert a chest drain through the diaphragm and into the esophagus. And unfortunately, everything that was then in the stomach emptied out into the chest cavity. So they can be, I mean, these patients can be really unwell, and it can be pretty sore. I think when it was first described, Herman Boerhaave I think he was doing an autopsy on kind of the admiral of the Dutch fleet who had apparently eaten a whole duck and 3 litres of beer. He then started vomiting, ruptured his esophagus, and Mr. Boerhaave managed to pick the duck and the litres of beer out of this fellow's chest, unfortunately. This kind of thing will almost always need kind of a surgical repair. And kind of it just shows the importance of a chest x-ray on these sorts of things that you can see here. I don't know how many chest x-rays you've seen, but kind of looking on this one, you can kind of see in and around here, this part kind of a bit widened mediastinum, you've got blunting of these costophrenics, just suggesting that you've got fluid on both sides on this one. Often it's unilateral. Possibility of air under the diaphragm here, suggesting that you've got a big tear that goes subphrenic as well. You're obviously going to get kind of stomach and air contents into the abdominal cavity as well as the thoracic cavity. It's a surgical nightmare, as well as probably not too pleasant for the patient either. I don't know whether it's particularly clear on this x-ray, but one of the typifying features of it is surgical emphysema. If you've not come across it before, try and get to a cardiothoracic ward and have a good feel of it. It feels similar to if you ever come across the wreaths that you used to make for Christmas, where it had kind of that foamy green stuff on the back. That's exactly what the skin feels like underneath. So surgical emphysema. They're often pretty shocked and unwell, and again, as you'd expect, difficulty swallowing. So again, these patients don't give them anything to eat, nil by mouth, NG tube to suck anything out of the stomach, and in extremis, you put in something called a T-tube surgically. So that's this thing here, where the T of the tube sits inside the esophagus. You repair the esophagus around the tube, that then sticks out and comes outside, and you get all of the nasty stuff externalized. Gives the esophagus time to repair, gives you time to give antibiotics to work on the chest cavity, and then after a certain amount of time, a couple of weeks maybe, this tube can then be taken out. And often the hole that it leaves will look after itself. Obviously, to get all the nasty stuff out, you've got to put your big chest drain in, and I'm sure you'll all know your anatomical landmarks for your triangle of safety for chest drain. So your axilla, fifth intercostal space, and then between your lap dorsal and your pec major. Again, a classic exam question. Similarly, for any shocked patient, good resus, give them some broad spectrum antibiotics, because it's not nice to have stomach contents in your chest, and an early surgical review for that sort of thing. So moving on to difficulty swallowing, now that we've talked about esophageal ruptures, I tend to split these up into kind of 4 generalized categories. The mechanical, so something blocking it going down, usually a cancer. Can often get, but you can get benign strictures, kind of an esophageal web, kind of retrosternal goiters, that sort of thing can push on the outside of the esophagus, making it difficult to swallow. Similarly, pharyngeal pouches, more commonly seen in the elderly, but worth noting those. Motility-wise, achalasia, failure to relax of the lower esophageal sphincter for whatever reason, whether it's mesenteric plexus problem, or you've got scarring or sclerosis secondary to reflux and the damage that the acid can do, or a condition called diffuse esophageal spasm, which we'll not touch too much on, but again, just worth kind of noting to rattle off. The inflammatory causes, a lot of them tend to be more upper, gastric tract, ENT infections, tonsillitis, candidiasis, specifically with steroid use. Reflux esophagitis can make it difficult and painful to swallow. And then there's the neurological causes, bulbar palsy, myasthenia, Parkinson's, motor neurone. Again, but for the purposes of the surgical talk, we'll focus kind of mainly on the mechanical elements. So key things to have a chat with the patient, make sure that you've got, do they smoke or not? I mean, it comes always, it's the risk of cancer. The one important question is the solids and then liquids, or did they both go at the same time? Difficulty swallowing. Difficulty with solids and then liquids suggests a stricture as a cause for the dysphagia. If they happen at the same time, then it's probably a motility or a neurological disorder. So it's just a way of kind of narrowing things down just with that one question. Difficulty swallowing saliva, again, think of a neurological cause, bulbar palsy, especially if they cough afterwards, it suggests that there's something wrong with the swallowing mechanism. Pain suggests a cancer or a spasm. Intermittent or constant. Intermittent suggests a spasm again, but constant suggests something a bit more worrying, suggests a bit more of a cancer. Neck bulge or gurgle, as you'd expect, you'd get your pharyngeal pouch, which goes with the halitosis as well. And just in terms of your red flag symptoms, if any of these you are probably worried about, well, the patient for starters, with a complete obstruction, and then the others, rapid progression weight loss, hoarse voice, melena, anemia, or their age, you're thinking about a cancer there. So that make sure that you get those in any history of dysphagia, especially if you're being examined, but more for the patient's benefit. The slant of this is going to take a bit more of an oncology kind of slant, just because that's what we're pretty good at cutting out rather than any of the other ones. So a bit of background to that. It's more adenocarcinoma nowadays. It used to be SCCs when everyone smoked and drank, but now with reflux, it's tending a bit more towards adenocarcinoma. Generally tends to follow the pattern of reflux to metaplasia. Therein lies your Barrett's esophagus, which will always score your points in an exam. Then different elements of dysplasia, and eventually to an adenocarcinoma. Just having a look at the speech and language therapist guidelines, dysphagia usually about when the lumen falls below 13 millimeters, so it's probably quite far on by the time they get symptoms. And in any adult new onset dysphagia, should always get an endoscopy no matter where you are, whether you're inpatient or outpatient. Worth noting kind of the blood supply of the esophagus. The upper esophagus drains the cervical nodes and up in the neck. The middle of the esophagus and in around to the mediastinum and the rest of the thorax, and the lower esophagus can drain into the abdominal nose and so it's kind of worth noting that you've got your Virchow's node, which is going to be a sign of an esophageal cancer, just because of the way that the lymphatics track, and kind of noting that obesity as well can have a bit of a risk factor on this. I think evidence isn't great, but there is a suggestion that localized inflammation from fat cells start producing cytokines, and it's this kind of low-grade rumbling inflammation that can predispose you to an adenocarcinoma. So how we're going to look at it? Again, your simple test, bedside bloods imaging, and then specials, so looking at your bloods, making sure that you can justify your full blood count, looking for signs of anemia, your urinase, see if there's any kind of bleed potentially, LFTs again, looking for liver disease, chest x-ray, it's going to have a look, and then your special tests, your endoscopy plus or minus a biopsy, because if you've got a big lesion, you're going to need to know what it is before you decide what you're going to do about it. Once you've had a look down there, if you've still got nothing to go on, manometry, which has a look at the pressure all the way down the esophagus, essentially that has a look over 24 hours. There's a little nasogastric sensor that has a look at you during a normal 24 hours. It sees when your acid load is at its worst, or whether the pressures around the esophagus aren't helping food get down and making things more difficult, because that in itself suggesting of a neurological problem. Swallowing studies includes swallow, where they drink contrast and take x-rays, watch it go down and see if there's any strictures that could possibly be causing the dysphagia. And if in doubt, if we do think we're going to have a CT anyway, chest abdo-pelvis, plus or minus a PET scan, so the positron emission technology, to have a look, see if there's any malignancy elsewhere. Fine, so kind of a little bit about cancers themselves. The use of the TNM staging, if you're not familiar with TNM, tumour, node and metastasis, and basically each one relates to how significant or how much the tumour has spread. T1 just into the no further than the submucosa, all the way to T4, which is malignant. So this is very important for MDT discussion and whether you're going to operate on them or not. It's worth knowing and being able to describe the TNM staging, if not knowing exactly what you do with each different stage, especially kind of in terms of prognosis. So tumour by itself can often be resected, but if you've got nodes involved, so that's your N level, where with 0 being no lymph nodes involved, N3 means kind of 7 or more nearby lymph nodes. Often you'll be able to find that out after an operation to remove the tumour itself. And that gives you an idea about prognosis for the patient. A little bit about therapy. I don't think you guys need to know too much about it other than that it exists, and the fact that you can have chemotherapy before surgery to help shrink the tumour and then take it out, and then you can give them a choice about whether they have any chemo or radio afterwards. We'll discuss a little bit later on, and we already have mentioned that these patients can be incredibly unwell, and the surgeries that they have are pretty massive surgeries. A lot of them might not feel fit enough to have the planned chemo radio afterwards, and so it's just worth knowing that it's always on a case-by-case basis. Some people might have some treatment beforehand, some people might just have treatment afterwards, depending on how fit they are. But just knowing that they're kind of options is probably quite helpful. And then in terms of cancer management, the key things to mention if you're being quizzed or when you're thinking about how you're going to manage a patient is palliative versus curative. Do we think we can do it all? And then this relates to your TNM staging. If you've got a T4 tumour that's spread to elsewhere in the body, you might do a palliative operation or palliative management to allow them to swallow, but you're not going to cure their cancer. So if you're going to do any surgery, you've got to do it with a curative intent. Anything else, nowadays, you can usually probably manage it conservatively, especially in the esophagus and they're having trouble swallowing. The big one is usually to put a stent in just to open the esophagus. Not without risk, the stents can slip down, but we tend not to do any surgery on patients that we don't think we can cure them with the procedure. As mentioned, the contraindications, METs to N2 nodes or solid organs. And a lot of that is the fact that upper GI cancers, if they have spread, they've not spread via the liver, they've spread throughout the bloodstream. So with bowel cancers, if they've spread to the liver, you can often resect a bit of the liver, and you can be pretty sure that elsewhere in the body has been spared because it's basically been filtered by the liver already. With the upper GI cancer, as we mentioned, because of the way the anatomy is and the blood supply and the venous drainage, if it's spread, it's probably spread outside of that liver filtration. So it's unlikely, if you've got solid organ metastasis, unfortunately, there's no real curative option. So depends on which unit you're in. In Sheffield, a lot of the endoscopy is managed by the gastroenterologists rather than the surgeons, but the surgeons will also be able to use endoscopic techniques to resect things. Often with your Barrett's esophagus or small tumours, you can use different ways: EMI, endoscopic mucosal resection, radiofrequency ablation, sclerotherapy, scarring it up, essentially burning away different these tumours and removing bits of Barrett's esophagus before they start to cause tumours endoscopically. And a lot of that will be done on an outpatient basis. So you'll never really see those as an inpatient on a surgical ward. But if they do need an operation to remove anything from the esophagus, the operation is pretty impressive to go and see. So this one on the left here, the Biliary esophagogastrectomy, which is 2 incisions. So the first incision is a laparotomy, at which point you'll probably remove a section of the esophagus, sometimes even a bit of a section of the stomach, and then you'll sew them back up. You can also do it laparoscopically. You then rock them on their side, open them up through a thoracotomy, pull the stomach up into the chest, and stitch it back together. So that's known as the Biliary esophagogastrectomy. And you can see now why we need patients to be fairly fit to undergo a procedure like this. They'll always end up on HDU afterwards. and the complication of these kind of surgeries are pretty significant. So if you had a leak, again, you're worrying about the same thing that happened in Boerhaave syndrome, where you get leaking of stomach contents into the chest. There's 2 wounds that are potential for infection. These patients are usually pretty unwell to start with. They'll come out with chest drains. It's an incredible bit of surgery, but not without its risk. And that's why people will often say that the upper GI patients are can be some of the most unwell patients, because not only are you battling with an abdominal problem if one of these goes wrong, but you've also got a thoracic problem. Taking that one step further is something called the McKeown, which, if you've got a particularly high tumour or a long tumour throughout the esophagus, you do the same thing, bring the stomach up, pull it up through the chest, and then anastomose it at the neck. Sometimes you might even defunction it. It's not very popular. It's much more popular in the UK now, but put a little esophageal stoma out into the neck while some of this recovers. You can then re-anastomose it at a later date. But, I mean, kind of pretty mad surgery, as you might imagine, and that's why these patients kind of are pretty well looked after on HDU afterwards. So that's a few of the big kind of esophageal cancer operations. In terms of gastric cancer operations, kind of 2 general ones: cancer of the lower part of the stomach. You can often get away with a subtotal gastrectomy, and the idea is essentially the same. You cut out most of the stomach here, trying to leave the fundus where you get a lot of secretion of kind of stomach hormones and digestive juices. Take it off the first part of the duodenum, remove the stomach, and then stick it all back together again. Because you've unattached it here, you've got a lot of pipes that go into your duodenum, most from the liver and the pancreas. You need to keep this little loop. This becomes known as the Roux-en-Y anastomosis, and that's your Roux loop and your Y loop. And hopefully you'll still be able to get your pancreatic juice and your bile coming into the bowel. This bit's pulled up. Similarly with a total gastrectomy, very similar, other than you don't leave the fundus of the stomach, and that's for a slightly higher cancer. If any higher than that in the stomach, and you'll end up doing an Ivor Lewis, because you won't have much esophagus left to anastomose it. So it's some exciting plumbing. I'm guessing that most of you want to do surgery, and kind of this is kind of the pinnacle of the surgical textbook. It's the big operation, is the Ivor Lewis and the bowel anastomosis, if that's your cup of tea. Other causes that aren't cancerous, we discussed a little bit about achalasia, which is another thing that we can try and help out surgically. This mess of pink here is something called Heller's cardiomyotomy. So whether you can see just here, this pink bit around here that I'm highlighting, that's the diaphragm. If you can imagine that you're looking from the patient's feet and up. So this along here is the esophagus as it's gone through the diaphragm. And these bits of fibre you can just see across here are the circular muscle fibres around the esophagus. And what's happened here is we've just sliced up through the muscle, leaving the mucosa underneath, and that allows the esophagus to stretch and allows food to get through. Unfortunately, doing that does mean that you're committing them to a life of acid reflux, so they're going to be a lifelong PPI after that. Other ways, if you couldn't do any surgical procedures, you can do things like a balloon dilatation, where you use an endoscope to put a balloon down, inflate the balloon and stretch it out. That probably needs to happen every couple of weeks or so. Botox to release if you've got a particularly tight nutcracker esophagus, as it's called. Calcium channel blockers have also been known to help a little bit, but they're not so much used anymore. And that's often done laparoscopically, as you can see there. So talking a little bit about dyspepsia now, kind of the acid reflux. Usually kind of red flags for this sort of thing, or in the history, once you see them, that older patients, bit of weight loss, rapid progression, these are all your red flags. If they've got any of those, they need an endoscopy. If they don't have any of those, so in a young patient with dyspepsia, try lifestyle advice to start with, over-the-counter antacids, sort of thing. And these are this is just pulled from the NICE guidelines. But essentially, with any dyspepsia, it's have they got H. pylori or not. In the over 55s, essentially, we're making sure that they don't have cancer with any of these red flag symptoms on the left. If they don't have any red flag symptoms, it's have they got H. pylori or not. So, if they've got H. pylori, various tests, you can do a stool antigen test, or if they've got endoscopy, you can use the CLO test, you can use a ureth test as well. But if they've got it, you can eradicate emission of metronidazole, coamoxiclav, and review it 4 weeks. If they've got better, fine, you've won. If they've not got any better, test them again, because your eradication technique might not have worked. Similarly, if they're on a PPI, as we discussed, your test for H. pylori might not be particularly sensitive, in which case stop any PPIs, antacids, start again, and go for there. So worth, I think it's in the Oxford Handbook, this thing as well. It's worth having a look, making sure that you eradicate it. Reflux disease, which we discussed, floppy lower sphincter, gastric malignancy, Jaundice and gastritis. Esophageal reflux disease, again, a bit of a plethora of causes. The one that I'm going to focus on a little bit is hernias, hiatus hernias, were a common exam question. And the take-home message from this really, know the difference between your sliding hernia, where the whole lot just slips up into the chest a little bit. That works out at about probably 80%, probably more, of the hiatus hernias that you'll come across. And then you've got a rolling hiatus hernia, where a little bit possibly of the cardia slips up above the diaphragm. Again, these things are going to give you symptoms of dyspepsia. There's two types. One of them is a bit of a combination, type 4, where you huge amounts of abdominal contents within the thoracic cavity. I think the most I've seen was stomach. I think there was a bit of spleen in there as well, certainly some large bowel. It makes for an impressive chest x-ray. Classifying gastroesophageal reflux, again, two names to drop when you're being quizzed about it by your consultant. Los Angeles classification and the Savory-Miller. I think the Los Angeles classification is more used. I mean, I myself probably still can reel those off the top of my head, but just knowing the names of them, at least you can then look it up, or say that you would look it up, are definitely worth committing to memory. So your conservative management, I think being a surgeon, it's not my cup of tea, this sort of stuff, but it does help, especially in a clinic point of view, or you've got a patient who's not fit for surgery. Lifestyle factors, stop smoking, making sure they sleep at a fairly upright position, aware of which foods cause the reflux, spicy foods, curries, caffeine, unfortunately all the fun stuff, alcohol, and then you can try your medical therapy, alginates, like a Gaviscon, PPIs, H2 receptor antagonists. But the real fun starts in the surgery. The fundoplication, which is a fun name to say as well as an operation to do. Essentially, you grab the floppy bit of the stomach, pull the hernia back down through the diaphragm, wrap the stomach around and stitch it to itself around the esophagus. That creates nice and tight, so you're essentially creating a new sphincter. And then you sew up the hole that you've left in the diaphragm. And it's a bit of a skill, placing your sutures, getting the tension quite right, but it works very well. Obviously, if you do it too tight, you're going to end up with dysphagia. So it's a bit of a spectrum. Here's one that's got a picture. Again, it's difficult to imagine, but you can see the esophagus running up here. This white bit here is actually the pleura of the lung. This one of the pillars, the right cruise of the diaphragm. Obviously, if they've got their feet towards you and they're lying on their back, this is the right, this is the left of the patient. This hole is going to need to be tightened up, so you can't see the lung anymore. and then this bit of the stomach is wrapped around itself. So again, pretty fun stuff to do. A little blast through jaundice. I'm aware of the time ticking by, so I will be as brief as I can. Usually present either painful or painless. Pain, it usually comes straight to the surgeons. Often intermittent, right upper quadrant. Painless is a bit more worrying, but similarly can have the same sort of causes. They'll come in with, someone will have noticed that their eyes are going yellow, just kind of worthy of note. It's very difficult to see if someone's jaundiced in lights in the hospital, kind of their halogen or strip lights. So take them to the window and have a look there in the daylight. Dark urines, secondly, is cutaneous jaundice when the skin goes yellow at slightly higher concentrations. It might also come in kind of pruritus, which is worth of LFT in itself, or itchiness of the skin, worth having a look at. So your initial investigation is what you do when you first see them. Again, justify all your tests, FBC, check for anemia, white cell count if they've got cholecystitis, which I think has been touched on already by some of the other guys. Calcium profile in your amylase is important because we'll talk about pancreatitis a bit later on. Similarly, clotting, if you obstruct your bilirubin, you can get deranged clotting. So it's definitely worth having a look at that because you might need to correct the clotting afterwards. Again, kind of Coombs test, haptoglobin, with things like hemolysis and kind of pre-hepatic causes of jaundice. And of course, your ultrasound abdomen is your first port of call. As you can see there, there's a little baby gallstone hanging on. So kind of we're mainly excited as surgeons by kind of this box here, but it's worth knowing and being able to rule out your other causes of jaundice, unconjugated and conjugated, before you make a fool of yourself in your referral. So again, kind of before you get anywhere, if you've got someone with jaundice, you can have a look at kind of causes of unconjugated versus conjugated. But for the purposes of this, we'll have a look at the kind of the cholestatic picture. For those of you kind of not, I always used to get confused with PBC and PSC. So as a bit of an aside, this website is great for just aligning the differences between primary sclerosing cholangitis and primary biliary, what used to be called cirrhosis, but apparently now is cholangitis as well. So that's worth checking out if you, like me, often used to get confused between the two of them. So kind of there's loads of acronyms in upper GI, and one of them that you can get confused, MRCP, is basically an MRI scan that looks at the biliary tree, do an ERCP. So if you've got on your ultrasound, it comes back and it says that your common bile has been dilated, but there's no stone, but because the patient's overweight, it's difficult to see, there's overlying bowel gas. You can take an MRCP, and often that will have a look in a lot more detail at the biliary tree, which you can see here. Here's the gallbladder, common bile duct, hepatic duct. This little skinny one here is the pancreatic duct, and if you can see both of those together, and they're both dilated, it's a bit worrying sign. It's called the double duct sign. That's suggestive of head of the pancreas tumour, which causes backflow of bile out both of them. It's another cause of your jaundice. So your obstructive jaundice, essentially initial management, analgesia, but cholecystitis or their inflammatory markers are raised. Often these are kind of E. coli based infections, one that naturally grows within the biliary tree. So you start with your broad spectrum antibiotic, but most of the time coamoxiclav. And then if you're going to do an intervention, your ERCP, your kind of endoscopic retrograde cholangiopancreatography, to try and either fish out stone or figure out what's going on. Laparoscopic cholecystectomy, done in the first instance, early presentation. If you linger on your laparoscopic cholecystectomy because of a stone and they get a bit more unwell, then it's often very dangerous, and you get what's called the gallbladder, and it makes it very difficult to remove without doing a lot of damage to the nearby structures. So in that sort of case, you can do something called a cholecystostomy, where you basically pop a little tube in for you to do an operation on them. Something you might also come across on an upper GI job is a PTC, which I'd never heard of until I started my upper GI job, percutaneous transhepatic cholangiography. So if you can't do an ERCP because we've done an ILOG on them, or they've got a cancer in their esophagus and we can't get an endoscope down, you can go through the liver. And that way you can also drain a lot of the bile if you struggle. And then kind of if it gets a bit more complex than that, you need a dedicated HPB, pancreatico-biliary surgeon, to try and bail you out. Essentially, the name of the game is to get the bile that's stuck in there out by whatever means possible. Kind of worth noting the risk of an ERCP. The main complication of that you need to let anyone know about is something called pancreatitis, which is a really, really nasty disease, and it can happen to anyone at any age spectrum. I mean, look, just the mortality alone of 12% is, if you had a chance of 12% of dying of anything, it's not something that you take easily. And essentially, the pancreas starts digesting itself. The more it digests itself, the more it releases enzymes that digest itself. The inflammation that you get from that causes absolute havoc within the body. And these patients get very unwell very quickly. About 20% of them develop kind of lifelong, life-threatening problems, kind of pseudocysts, recurrence, necrosis of the pancreas, abscesses. You can get, the inflammation can actually cause thrombosis of all the nearby blood vessels, and these patients just keep coming back more and more unwell. So being able to recognise this, I think, is really, really important. Significantly knowing your modified Glasgow criteria, which quite conveniently spells out the word pancreas. And I think in my medical school finals, that was one of the questions, was to list them all and why we do them. Kind of just an interesting note about the calcium, why it becomes low. Kind of depends where you look, really, but it seems to be because the digestion of lipids, so the saponification, uses up a lot of calcium, and it's often a pretty good marker of how severe the pancreatitis is, by how low the calcium is, rather than the amylase, which is kind of your traditional way of marking out pancreatitis. How high the amylase is doesn't necessarily reflect how bad the pancreatitis is. These guys will present with a epigastric pain radiating into their back. It's usually either due to a gallstone that's passed by the pancreas, it's tickled the pancreatic duct on its way out, and it causes a reaction of inflammation. It's very difficult to stop. But also on your ERCP, this is what we worry about. So these patients are pretty unwell. They're often managed by the surgeons, not because we need to do anything surgical, but often because I think we're a bit better at managing the pain relief, fluid resuscitation. You can do a pancreatic necrosectomy in extremis, but often kind of doing surgery on these patients makes it worse. So often we just try and leave them to ride it out, call HDU early. And that's mostly it, really. I didn't know if anyone had any questions at this point, or whether kind of anyone can put any questions to me. Do you want me to keep my slides up?
I don't know if you can hear me. Can you hear me? Oh, yeah,
Yes,
fantastic.
yeah.
So we did have a couple of questions, but if you'd like,
sure.
I was going to briefly just summarise them. A lot of them are about PPIs
Okay.
and just use. I wasn't sure whether to answer them as we went along or to continue, but I think most of them actually were answered in your very useful flow diagram. Briefly, they were just about whether PPIs should be held. I'm going to just briefly summarise them, and then you can talk about in general about PPIs if that works. Whether PPIs should be held after endoscopy. Why would you start on a PPI and not on something like ranitidine? And then there was another question. One, I think about the effect that it has on the H. pylori testing. I think you summarised very well. But do you have anything in response to that to add about PPI? So
is that kind of why do you stop the PPI before endoscopy, or would you just restart it straight away?
Yes, yeah, pretty much.
So yeah, I think for the endoscopy, depending on why they're having the endoscopy, if they've got a big bleed, I think you've just got to suck it up and say we're going to keep them on the PPI throughout the endoscopy and afterwards. If you are doing an endoscopy for dyspepsia or kind of an acid-based problem, or you're worried about kind of Barrett's, if the patient can tolerate it, which I think is the biggest problem often that you come across, is that the patient will refuse to come off their PPI. If the patient can tolerate it, then as soon as the endoscopy has been done and you've got samples following the 2 weeks without the PPI, you can just start them back on it again. There has been kind of a bit of a hoo-ha in the media about actually an increase in gastric malignancies and people using a PPI, but I think it's very tenuous evidence, and I think the risk-benefit of these patients with a PPI of contracting a gastric cancer without PPI falls in favour of just using a PPI anyway.
No, that's very useful, thank you. And briefly, from my experience, I think ranitidine isn't used in hospitals anymore just because they can't get it, so that's why PPIs...
Yeah, no, they're using... I've got a little thing, yeah, I can't remember what it begins with an F. There's a different one that because we can't get hold of ranitidine. But similarly, I think kind of objective research suggested that PPI is a bit more effective, and I think half of it is also probably because it's a bit cheaper.
Fantastic, that's great. And there are a couple more questions. I might also very kindly say that if people have further questions that don't get answered just because of time limitations, they might be able to email you and actually very kindly put your but briefly, if we've got time, just there was a question about the urea-creatinine ratio and just the importance.
Okay.
I don't know if you could summarise briefly.
Yeah, so I mean, I don't think, well, there probably is a fine art to it, but generally, once you're looking at the U&Es, if you've got a marked increase in their urea without a significant increase in their creatinine, so even if they've got kind of a bit of a CKD going on, their creatinine's 120, but their urea goes from like 6.5 to 17, 18, 19, then it suggests that it's probably not a renal cause. If your urea goes up as well as your creatinine goes up, and they both go up quite significantly, you can usually assume that it's probably a fluid or a volume related issue. So kind of it's a bit of a judgment call. If you've got all the other signs of kind of, and probably possibly a falling HB, maybe have a bit of a melena, as well as a sudden rise in urea, unexplained rise in urea without a significant rise in creatinine, and I would take that as a pretty sensitive marker that they have a GI bleed at some point. And I think people would do an endoscopy just on the basis of that.
Fantastic, that's really useful. I was just going to say, feel free to continue on to some of your tips, and can always answer some more questions at the end.
Okay, yeah,
it's completely up to you. You can also put on your feedback or QR code, or talk to us without your slides, depending on fancy.
Well, I'll put this on quickly and just kind of rattle them around about just things as an F1 that I found have been quite useful. And I asked a load of my F1 colleagues that I worked with on the upper GI job, what do they wish they knew when they started? So kind of learn the consultants' names. That's really helpful. You don't know how difficult it is on a ward round if you're trying to start the ward round by writing ward round led by Mr. and then you don't know the consultant name, and you can't ask the consultant right in the middle of the ward round. So know the names beforehand. Learn to prescribe fluids properly though. I think there's a couple of courses online. If you want to email me afterwards, I can send you a pretty good way of prescribing fluids for different occasions, when they need Hartmann's, when they need saline, how much to give them, how fast to give them, because that is always at 4 a.m. the nurse will call you and say, can you prescribe fluids for my poor lady? And you won't know, and there is a good way to do it and a not so good way to do it. So let me know if you haven't already looked it up, and I'll send you a link. Another thing, kind of working on a surgical job, the instructions will often be at the end of the op note. So as soon as you know that a patient's to the theatre, have a look, because there might be something on there like omit their dalteparin until 10 p.m. That's pertinent to that night. It can be as soon as that. But also, if you don't understand what's on the op note, or you need to ask a question about it, you need to ask it before the surgeon has gone home after the operation at 5 o'clock and he's got changed. So make sure that you're just aware and keeping up to date with that. Antiemetics on a general surgical job, it's super helpful to know kind of why different antiemetics work in different situations. So kind of chemotherapy associated nausea, why you'd use a 5-HT antagonist like ondansetron, or in certain situations why you'd use cyclizine. Again, I think there's a really good bit in the Oxford Handbook about that. But just kind of tailoring your antiemetic to why they're nauseous will make your life so much easier, and it will make you look pretty impressive in front of the other docs too. A little thing about writing in the notes: the first line in your note should be why the patient is there. Day 3 post cholecystectomy for gallstone cholecystitis, and then at least you know what's going on, because it can be a bit cloudy if you start your new job. People are saying, oh, fiddle around with his bisoprolol, tinker a little bit with his lansoprazole, but you don't actually know why the patient's there. So make sure that that's clear. And then the sepsis 6, I hope you've come across it. You can use that in all situations, not just for sepsis. If you've got an unwell patient, put some oxygen on them, take a gas, make sure you get a lactate, put some fluids in, put a catheter in, and take some bloods, and maybe start some antibiotics, because it's much easier to do that and then take it off than it is to wait for an extra hour and the patient get more unwell. So there's just a few little tips, but I'll put my email on. Ask me if you've got any questions. I'm always happy when I can to respond to them. And then equally, kind of ashamedly going for a bit of a call for feedback. In terms of, I'm sure you'll come to it because you'll all be great surgeons, I know. But when you come to your interviews, kind of for core training, core surgical training, or registrar training, having some really good feedback that you can talk about in your interview really makes a big difference. And if you've got something that you can talk and impress an interviewer about, it's going to score you a lot more marks than just working up. So I would appreciate some wonderful feedback in the same way that I'm sure you will appreciate the feedback when you're doing this talk in 2 or 3 years and you're asking the medical students to give you something, some ammunition for your interviews coming up. So I'm not even sorry.
Fantastic. No, that's been really great. I think there's just been a few things about people accessing the slides and the emails, which is great. But just wanted to say a huge thank you, Dom, for taking time out of your busy on-call shift to come and teach us. Learned a lot from that. Learned a lot from your teaching session, so it was really, really useful. I don't know if you had any more time to go through some questions, or whether we end it.
Yeah, well, my bleep's not gone off yet, so if there are any pressing questions.
Any pressing questions? I'm just getting them up. Somebody asked about patients with an upper GI bleed developing melena. Don't know if you know from personal experience off the top of your head if kind of how common that is, and if there's any.
Fortunately, I've never had melena, but in terms of experiences of patients with melena, I think it happens more often than you think, and a lot of the time it's because they don't actually have an upper GI bleed. You'll often get someone saying, oh, this patient's got melena, but they're actually just on iron, and it's very difficult to tell, or they've got hemorrhoids, and you've got them on a surgical ward and they haven't had enough laxatives and they've kind of started bleeding everywhere. But you'll get used to kind of, I mean, it sounds pretty gross, but assessing it, and upper GI bleeds, most of the time they will be found because of melena initially on an inpatient setting. So whilst you're in hospital, the nurses will always say that it's melena, but always have a look, make sure that if they haven't got anything for you to look at, then say next time, let's have a look. And then you can judge for yourself. I mean, I appreciate you probably haven't seen much melena at this point, but you will get to know what it looks, and more unpleasantly, I do apologise because it is dinner time, kind of the smell of blood.
No, that's really
and you get used to it, and then at which point you need an endoscopy. So I don't know whether that answers the question. But.
Yeah, definitely. No, that's very useful. I think we've got time for 2 more questions, maybe. I was just going to say, there's just somebody who asked, what would you discuss personally, I guess, if you're putting an F1 hat on, if you had to discuss with haematology about anticoagulation with patients with a suspected upper GI bleed, what would be the things that you'd want to talk about? Okay.
Fine. Yeah, good question. I'm just going to unshare my screen, if that's okay. So having a chat with a haematologist, I would want to know, one, what specific clotting tests, because often they'll want to know platelet function tests, or they'll want to ask for specific clotting factors that only haematology can ask for if they're worried. So if you've got someone on apixaban or clopidogrel, or they're undergoing or they've been kind of on cardiopulmonary bypass, there's going to be a lot of things that the haematology will think about that we would have no idea. So just a cursory call saying, I've got a patient who I think has an upper GI bleed, that we're going to send them to endoscopy, but they're on apixaban. What blood tests do I need to request? If it's a big GI bleed, often it will only be haematology that can give you kind of the beriplex and things like that, just because it's super expensive. You would ask if they need any extra blood products. And then you'd probably go even so far as to say, over the next few days, kind of at what level should we be transfusing him, after how many blood units should we give him some platelets and some clotting factors. Because the difficult thing with giving someone loads of red blood cells, which, because you're always chasing the haemoglobin, is that you end up diluting the rest of the clotting factors, and these patients become really, really kind of leaky. They just don't clot at all, which is an absolute disaster if you've got someone trying to tie off a leaking variceal bleed at endoscopy and the blood is hosing out. So yeah, I think I'd go for kind of what factors do I need to give him, blood clotting factors, what blood tests do I need, what point do I transfuse him, and kind of any other blood investigations that are kind of haematology only requesting, and then see what they say. Usually they're pretty helpful in that sort of emergency situation, I have found anyway.
Fantastic, that's really useful. I think on that note, we will let you get back to your shift. Just want to say a massive thank you. Really, really informative. I definitely learned a lot, and really appreciate you giving up your time. So big virtual round of applause from everybody. Thank you very much.
No problem. Good evening, guys.